We are live.
गुड इवनिंग। माँ दुर्गा को नमस्कार। तू शक्ति है, तू तेज है, तू प्राणों का वेग भी है, तू सिद्धि है, श्रेष्ठ भी है, समस्त तू है, श्रेष्ठ भी है। ऐसी नारी स्वरूपा माँ दुर्गा को मेरा शत शत प्रणाम। इसी के साथ माई सेल्फ डॉक्टर कंचन शर्मा, चेयरपर्सन ऑफ नॉन कम्युनिकेबल डिजीज कमिटी फॉक्सी, वेलकम यू ऑल टू दिस 59th episodes of podcast Gyan Pravah series. Today is 28th March. On each 28th, I will be there with some great national or international faculty, as we have seen that previous episodes, all the 58 episodes were very much liked and seen by our all the 46,000 Foxians, even many non-Foxians. This has been a most popular program, and because daily we do meet to some great personality, hear them, learn some new things from them, and follow them. So, this beautiful theme has been brought by the brainchild of our most beloved, devoted, and visionary Foxy President, Dr. Sunita Tandulwadkar, Madam, who is at present our Foxy President. She is HOD of the Ruby Hall Clinic and IVF Center, Pune. She is president-elect of ESAR and is devoted 24 by 7 and 365 days. Under her expert guidance, we all are doing many programs through Foxy. These are the Sampurna project, that is a woman should conceive only when she is Sampurna. That is, she is free from all the diseases. What a great idea. दो टीके जिंदगी के, know your numbers, and many more. ऐसी ग्रेट सोच को एंड डॉक्टर सुनीता तेंदुलकर मैडम के लिए मैं दो लाइनें जरूर कहना चाहूंगी। समुंदर सी गहराई है मैडम आपकी सोच में, समुंदर सी गहराई है मैडम आपकी सोच में, सफलता सी सच्चाई है आपकी खोज में, सफलता सी सच्चाई है आपकी खोज में, चेहरे पर आपके रहती है हमेशा मुस्कान, चेहरे पर आपके रहती है हमेशा मुस्कान, आप बिना लिप्त हुए भी करती हैं सबका सम्मान। आपको शत शत नमन। आज मेरा अहोभाग्य कि दो दो ग्रेट पर्सनालिटी, national and international figure, are with me in the same frame, and I invite our Foxy President, Madam, to bless us and this podcast.
Thank you, Kanchan. First of all, I'm touched with your poem. I never knew. I knew only Dr. Alka Kuthe, who keep on writing and this thing. Nevertheless, I'm so happy that today you have chosen the liver disease with pregnancy, the most important topic for a dialogue with yet GI surgeon, the liver transplant surgeon. I think it will be very much beneficial to all our Foxians. We all are always worried when it comes to liver diseases during pregnancy. And I know at Ruby Hall, we manage this being a tertiary center so common. And believe me, even if we are in a tertiary center, when such patient gets referred, we always have a feeling, oh my God, why we? Because it's a tough journey to handle the pregnancy with the liver disease. So always you come out with the brilliant faculty. Your dialogues are amazing. And Kanchan, it is always, you speak from your heart. You have very pure soul. And it's lovely to interact with you. Dr. Anil Arora ji, thank you so much for coming on a Foxy platform. And it's an honor to have you. 46,000 gynecologists, but this podcast goes live on a social media. So even non-Foxians are the viewers. So I think many more will get benefited with such an intelligent dialogue. Thank you, Kanchan. As the
Thank you.
protocol, after your introduction about Anilji, I'll be leaving the podcast and I'll be joining from the viewers link, and you both will be shared a beautiful frame together and enjoy your 30 minutes journey.
Thank you, Madam. Thanks for your blessings. Today only I came to know that Madam's husband was also a great liver transplant surgeon. She has
No,
the
he
story.
did not enter into advanced this thing. He was in 2006, Anilji, he was with Raila in London.
Okay.
And that time it was very preliminary in India, 2 decades ago, about the liver transplant when they came. Even Ruby Hall license ones on his name till I think 2020. But by that time, he was settled so much in his routine GI endoscopic surgeries that sometimes you have to choose either this or this. Yes,
So,
Kanchan.
so thank you very much. There is a great academician, Dr. Anil Arora, sir. Uh, he is MBBS DNB, MD, DM Gastro from prestigious AIMS, and he subsequently obtained his liver transplant fellowship from Queen Elizabeth Hospital, Birmingham in 1999, and he was awarded fellowship of Royal College of Physicians of Edinburgh, FRCP, Edinburgh in 2004, and Fellowship of Royal College of Physicians of London, FRCP London in 2014. At present, he is chairman of the Institute of the Liver, Gastroenterology and Pancreatic Biliary Sciences at Sir Gangaram Hospital, which is one of the premium academic institution of the country. Beside providing a high standard of clinical care to the patient, he has been regularly writing the scientific articles in the national and the international journals, leading to over 240 publications in the indexed medical journal, bedside authoring a number of books chapter. He has a great interest in study of the viral hepatitis and as well for the expertise in treating the chronic hepatitis B and C infection, hepatocellular carcinoma, stem cell therapy in the liver disease and the liver transplantation. He keeps himself updated with the latest trends in medicine with an inquiring and inquisitive mind. Presently, he is also the head of liver transplant team and coordinates all the academic activities in Institute of Gastroenterology and Hepatology at Sir Gangaram Hospital. He is very skilled endoscopist, regularly performing ERCPs and all the type of therapeutic endoscopic procedures. He was instrumental in the set up of a first advanced diagnostic and therapeutic endoscopy setup in the private sector in the North India, has been spearheading the endoscopy teaching program for all 3 decades. He is heading the third space endoscopy program with experience of more than 500 poem. Procedure is the leading center of the advanced endoscopic procedure of the multi-head tapestries, having successfully conducted almost 20 therapeutic endoscopy workshop over the last 2 decades. He has started the first ever structured in-house certificate course in GI mortality, which is often neglected in academic curriculum. Training comprises of hands-on training coupled with didactic lectures of training of budding gastroenterologists from India and abroad. He is soon starting the first structured hands-on certificate courses in endosonography for the young students after passing their DM or DNB gastro exams. He has been a regular member of the various task forces for GI and hepatobiliary diseases in India and abroad, and was the chief architect in formalizing the Indian guidelines for management of the hepatitis B immunosuppression and HBV, liver disease in pregnancy, kidney and the liver disease, and anticoagulant and the antiplatelet agent in the patient with the GI bleeding. So such great is the CV of our today's international and national faculty. Sir, it's my pleasure to welcome you here on behalf of Foxy, and Madam is there.
Thank you, dear. Thank you.
Thank you.
Lovely to have you, Anilji.
Thank you. Thank you.
And just one line, I just realized when she spoke about ERCPs and all, Dr. Rajesh is the only GI person in Pune who does lap coles, lap hernias, everything laparoscopic, as well as ERCPs and all upper and lower GI operative scopies.
Oh,
So
the dual work.
Yeah, because he was with Dr. Nande, sir. So
Okay.
Dr. Nande does ERCPs and all and lab college also. So 1991, we have come to Pune and we started our setup. And in last 35 years, I don't think there is a single gastro surgeon who can do the ERCPs and everything. And the gastrophysician, of course, there's no question about lab surgeries.
So that is advantage actually.
Advantage, tremendous advantage, sir. But lovely meeting you and
I
see you
I see.
sometimes. Thank you.
Okay, thank you, sir. So, again, on behalf of Foxy, I welcome you to this podcast series.
Thank you. Thank you so
The topic chosen is also great. And I think by this podcast series, we all Foxians will be more and more benefited and enlightened. Sir, my first question to you is that because as I have read in your CV that you did a lot many training and you are doing the training programs also for the upcoming generation. And what was the thing who brought into what was your passion, why you adopted this gastro surgery and the liver transplant, etc. What was the reason which brought you in this so much of the academics and this liver surgery and gastro surgery?
much. First of all, Dr. Kanchan, thank you so much for giving me this honor and pleasure of being with you in such a big gathering of 46,000 Foxians. I'm really amazed at the quantum of the people who are interested in understanding the subject of liver disease in pregnancy. So this goes, I think, it gives you complete credit for sustaining the interest on day-to-day and week-to-week basis as the people get glued to the basic questions which you tend to clarify, especially when they hover around the other illnesses in and around the pregnancy. Regarding my interest in hepatology, I had been academically interested as I completed all my medical education from the prestigious All Indian Institute of Medical Sciences, MBBS, MD, and DM. And then I joined Sir Gangaram Hospital, which is one of the best premier academic institution in the private sector. So I joined in 1991. Till then, it was thought that academics primarily belongs to the government institution and the private institutions are there to make money. So that is no more true. The people in the private practice, they handle 80% of the work in the medical service in the Indian sector. And I think this is something which has come up over the last 40 or 30 years. So
Right.
as I had a good academic background, so in 1999, there was there is one event which changed my course of further development in the field of
Yes.
gastroenterology.
Yes.
So we had a industrialist son who
Mm,
came to Gangaram Hospital to our founder president in Gangaram called Dr. S.K. Sama, which most
mm,
of you would have heard. So Dr. Sama had established the Department of Gastroenterology and it had good credentials. So this young boy was an industrialist son, was suffering from Budd-Chiari syndrome
mm,
and needed liver transplantation. At
mm,
that time, as Dr. Sunita said, the liver transplantation was not available in India. I'm talking of, end of the last century. So since this industrialist son could afford the treatment, so we took him to a place called Cromwell Hospital in London under a surgeon called Dr. Nigel Heaton. I was the treating physician and treating hepatologist for this young boy. And we were told the total amount of expenditure will be around 10 million rupees, which is 1 crore Indian rupees, way back in 1999, which will be equivalent to something like 20 crore in today's currency. So after we got admitted in that hospital, one single room rent was 700 pounds. One ultrasound will cost you about 20,000 rupees. See, as an Indian, you always compare your expenses with what you are spending in your own country. And there was a huge, humongous difference between the two. So we exhausted the money within 1 to 2 weeks, and there was no sign of liver being granted to us. So finally, we made our journey back, and unfortunately, we lost this young man who could have survived on liver transplantation. So that is what gave us the kick as to why, after being good academically, after being competent in your subject, why is it that we were not doing liver transplantation? So I was sent as a first transplant hepatologist to be trained in Queen Elizabeth Hospital in 1999. And we had our surgical colleagues, Dr. Subhash Gupta and Dr. Soin, who propelled me to learn transplant hepatology. And once I was trained and I came back, we started the program in the end of this century. So it took us 2 to 3 years to establish the program. And by 2005 and 2006, we started successful program for the first time in India and possibly Asia. And over the last 2 decades, we have propelled and we have ascended to a level where we are the leading living donor liver transplantation center in the world, not only in Asia. We have been getting patients from all over Asia, from South America, from Central Asian countries, and even Europe. And this is the success story of a kick which was given to us because we thought, why shouldn't we be handling the thing? So that is something which I still remember
Great,
clearly.
great to
That is
hear, sir.
what gave
And
me the interest to become a hepatologist.
congratulations. By this small incidents, our country got a great liver surgeon, liver transplant surgeon, and gastro surgeon like you. Sir, thanks for telling this interesting story. And now, coming on the topic, it's my question that we obstetricians and gynecologists get many patients where the liver disease they complicate the pregnancy, or sometimes there is a pre-existing liver disease, sometimes there is coexisting liver disease. So first of all, how do you classify them? How should we interpret the patient who are coming to us in the pregnancy or before the pregnancy? What should be the planning?
That is a very relevant question, ma'am.
Thank you.
There are multiple ways of looking at it.
Yes.
So the relationship between the pregnancy and the liver, I shouldn't be saying liver is the most important in the organ in the body because I'm a hepatologist. But if you look at the weight of the liver, the number of functions it performs, and the relevance of the liver in the body, I don't think any other body organ can ever compete with liver. The liver is the prime organ in the body. It is the prime minister for a, say, for a Lok Sabha or something. So the relationship between pregnancy and liver diseases may be wholly or unholy. So you can have pre-existing liver disease like viral hepatitis, hepatitis B, alcoholic liver disease, autoimmune hepatitis, or primary biliary cirrhosis, in which young women will incidentally or accidentally get pregnant. That is the first set of the group patients. Second is the set of the patients in which a pregnant woman who was otherwise normal can have a liver disease, as would happen, say, in a male or a non-pregnant woman. Classical examples are drug-induced liver injury, dengue-related liver injury, viral hepatitis, or gallstone-related obstructive jaundice. That can occur for me, for you, for any non-pregnant person. And then finally, there are some diseases which are primarily related to presence of pregnancy. So they are classified in different trimesters. Like in first trimester, you're likely to have hyperemesis gravidarum. And in the second, third trimester, you are having classical. I'm sure as obstetrician, you will have far better knowledge than what I possess as a hepatologist. Then this group of the illnesses called fetoplacental syndromes, which includes preeclampsia, eclampsia, acute fatty liver of pregnancy, and HELP syndrome, which are typically related to presence of the pregnancy. They will never occur in a non-pregnant state. So that is how we classify pre-existing disease, incidental disease, and diseases occurring and ensuing because of the pregnancy.
Right. So being an obstetrician, we will just start discussing about the first trimester diseases which are due to the pregnancy or related to the pregnancy. Like, first of all, can I ask you about the hyperemesis gravidarum? Sir, how the liver function is affected by this and how the liver function that changes during the pregnancy? So please.
In fact, there is a very good review if you look at what hyperemesis is. If you try to split the definition of hyper means more, emesis means vomiting.
Right.
So any pregnant women in the first trimester is likely to have nausea, retching, and vomiting. But if that is exaggerated to an extent where you need to seek the help or it affects the health of the mother or the baby, that is a pathological condition called hyperemesis gravidarum. In fact, if you look at the world literature, 1 to 2% of all pregnant women will have this, but up to 10% of incidence has also been quoted, especially in the Western population. Somehow, Indian women and Asian women are more tolerant to occurrence of hormonal changes ensuing within the first trimester of pregnancy. And the reason mentioned is there is a direct relationship between the beta HCG level and the occurrence of the nausea. So
Right.
beta HCG starts rising within 2 to 3 weeks, is peaks at the first trimester of pregnancy and then gradually settles down. Similarly, if you look at the hyperemesis gravidarum, it will start on 4th week, gradually will go up at the peak in the first trimester and gradually it will settle down. So it's because of the changing hormonal milieu which gives you repeated vomiting. And fortunately, most of the patient can be easily managed. Very small number of the patient need to be admitted for further assessment.
Important reason which you are said that hyperemesis gravidarum, I think liver function is affected. So will you put a light on how the liver function that varies during the pregnancy from the normal one?
Yeah, in hyperemesis gravidarum or otherwise also. In otherwise also in a normal pregnancy, there are some alterations in the liver function test, because by default you have hypervolemia, you have more blood flow to the liver, you will have hemodilution. So there may be a bit of rise in serum bilirubin. Alkaline phosphatase may rise because of the extraneous factor, because alkaline phosphatase may also come from placenta, and gamma GTP may go down, albumin may go down. So in general, there may be small alteration in the liver function test in a patient who is otherwise normal. In hyperemesis gravidarum, at times you can have, because of the repeated vomiting, you may have ketosis, ketonemia, and slight alteration in the liver function test. But liver function test alteration is not a big issue in hyperemesis gravidarum compared to other second and third trimester diseases like eclampsia or HELP syndrome or acute fatty liver of pregnancy, where liver takes the brunt of the disease process.
So usually hyperemesis that happens in the normal case, maybe in the twins also, maybe in the vesicular mole also, we have to distinguish it from the liver diseases. So coming on the second trimester, we can come on the cholestatic jaundice of the pregnancy or cholestasis of the pregnancy. Many often we do face the patients who are suffering from the cholestasis. They are coming to us in the late second and the third trimester with the itching throughout the body and which is intolerable. So does it affect the patient or the fetus or the outcomes, and how to manage, sir?
Yeah.
The answer.
There is a disease entity called intrahepatic cholestasis of pregnancy,
Right.
in which, because of the altered hormonal milieu within the liver and within the body, there is a effect on the excretion of the bile salts across the bile canalicular membrane into the biliary tract.
Right.
So since there is a exit block, so there is a accumulation of the bile salts, and which tend to get retained within the human body. And once they get deposited in and around the nerves and under the skin, they give you pruritus and alteration in the skin color. Typically, the disease will respond beautifully the moment as soon as the pregnant woman delivers the baby. But till the delivery is not happening, or if you the problem is starting, say in the late second trimester or early third trimester of the pregnancy, patients may be miserable because of the itching, because of the retention of the bile salts. So there are a lot of therapies which have been in vogue for giving symptomatic relief. That is for in the form of, say, UDCA, or there are newer drugs which are coming into being,
Yes.
ursodeoxycholic acid in higher doses. This is the only established safe therapy for treating intrahepatic cholestasis of pregnancy. There are other drugs like rifampicin or cholestyramine, which are called bile acid sequestrants. That means they will not let the bile get absorbed from the intestinal circulation. All of us know the bile which is excreted into the intestinal tract, 90% of it is reabsorbed into the body. This is called enterohepatic circulation.
But nowadays, rather than cholestyramine, we do prefer ursodeoxycholic acid in the pregnancy. As you have.
Enterodeoxycholic acid is a hydrophilic cholic acid. So it replaces the damaging hydrophobic bile acids which are getting accumulated with the hydrophilic acid. So it gives you more safety for the mother, lesser injury to the liver, there is improvement in the enzymes, and that is how it is found to be useful and totally safe in pregnancy.
Oh, thank you so much. The other things by which we obstetricians are more commonly facing the condition like HELLP syndrome in the preeclampsia, eclampsia, as you were saying, and the acute fatty liver. I just want to know about both, how we have to differentiate both, and what is the prognosis in both the cases.
Yeah, as Dr. Sunita in her introductory remark, your Fogsi president very rightly mentioned that when the patient with all these diseases comes to a obstetrician or a multidisciplinary team in which we have a hepatologist, pediatrician, anesthetist, and gynecologist, obstetrician. So for them also, it's not easy to distinguish the two. But I'll give you very simple clues. As a practicing gynecologist, you can just remember it on the fingertips. So these are called feto-maternal diseases, in which there is something wrong with the placental and the fetal and maternal collusion. There is something wrong which affects multiple organ systems. So most of these patients will have pain, nausea, right upper quadrant pain, altered liver function test. So how do you distinguish between the three? Simplest clues are that if you have a combination of hypertension and proteinuria, that is more likely to be eclampsia or preeclampsia. If you have low platelet count with hemolysis, you are likely to have HELLP syndrome. And if you have a rising INR, if you have rising ammonia, or if you have hypoglycemia and very high enzymes, so that is a clue to the presence of acute fatty liver of pregnancy. If you look at different criteria, there is so much of the overlap between the three because possibly pathogenetic mechanisms are also overlapping. Because as I said, it is a feto-maternal problem, interaction problem. So if we just remember the simple cardinal rules, for proteinuria and hypertension is eclampsia, low platelet count and hemolysis is HELLP syndrome, and rising INR and very high enzymes and low glucose, that will be acute fatty liver of pregnancy. Of these, acute fatty liver of pregnancy is the most uncommon. In fact, even in the world, not more than 1,000 cases have been reported till date. It typically is very uncommon in Indian scenario. And we have more problems. Like eclampsia is far more common than other conditions like acute fatty liver of pregnancy.
So really, acute fatty liver is a very comparatively uncommon condition, but a comparatively more fatal. So even in these cases, we have to terminate the pregnancy to save the life of the mother, as well as in case we may save the fetus. Preeclampsia and eclampsia is more common condition comparatively, in which we face the HELLP syndrome, and we have to see about the platelet count and the hemolysis also.
You very rightly said the diseases which are occurring in the mother-fetus interaction because of the pregnancy, the treatment of choice is delivery. The earlier, the better. But you, as an obstetrician and the pediatrician, as the person who will be looking after the newborn baby, you have to take a call, whether it is to be done at 32 weeks, 34 weeks, or 36 weeks, depending upon the maturity of the fetus, the ability of the pediatrician to handle the baby, as well as the degree of liver dysfunction and other collateral damages which is occurring because of the pregnancy. So that is a call which has to be individualized. It is to be taken in a multidisciplinary board so that both the baby as well as the mother remain safe. So the treatment of choice in all pregnancy-related diseases, if get rid of the pregnancy with the safety of the fetus, and that has to be individualized. You cannot have a clear dictum and clear guidelines for every single patient.
Thank you. Very rightly said. Sir, now there are few in your CV, as I was saying, that you have a specialization in infective diseases studies. Like if a patient is suffering from hepatitis B or C, as we obstetrician now from at the very first visit, or the patients who are coming us to take the consultation about the infertility, and we are getting their investigations done. These are the HBsAg, HCV, and all, HIV. And what is your recommendation about if a patient of this type comes to us before conceiving? So till how much time we will say that don't conceive? To be safe, should we see the viremia or viral level, or once she conceives, after that we get the investigation, or during the labor? What are yours say? Sir, I just want to know your views.
Yeah.
Expert.
See, as a practicing obstetrician, it is very important for you to know about two things: contraceptions and the investigation, which are to be dated, to be antedated prior to their becoming pregnant. So,
Right.
our young women who are destined to become pregnant will see you for two reasons. One is for contraception, in case they want to delay the occurrence of pregnancy, or else if they are planning to conceive. So, what all should be done prior to their conception? That is a very relevant question. Three things we have to ensure in all patients who are planning to conceive: hepatitis B, hepatitis C, and HIV. In
Yes.
fact, if the mother is protected against hepatitis B, you do a simple test called hepatitis B surface antigen, anti-HCV antibody, and test for HIV. I'm sure this is a mandatory requirement by law, by the medical council, and I'm sure by Fogsi. All
Yeah.
antenatal mothers or mothers likely young girls likely to conceive should get all these three. Now, in case unfortunately this young girl is suffering from any of these, then depending upon the level of viral replication and the degree of the liver damage having occurred because of these diseases, we have to take action accordingly. In hepatitis B, there is a very simple drug called TAF or tenofovir alafenamide. We have very excellent drug and very lovely drugs for hepatitis C, which can totally cure the virus, called direct acting antivirals, or DAA. And in HIV, we have drugs which can be almost curative. So if you
These drugs are, few of these drugs are safe in pregnancy also, sir. No? Yes.
at least for hepatitis B and HIV, the drugs which you are likely to give, even if the lady wants to continue pregnancy, they are safe drugs. Except that you have to inform your treating doctor. He will look at the composition of the drug, which is safe, which can be continued even in the first trimester of pregnancy. Let's talk of hepatitis B. If for different indication, this lady requires antiviral therapy for hepatitis B, we never discontinue. We will continue drug like TAF, which now has been proven to be totally safe in pregnancy, even in the first trimester of pregnancy.
Right.
The reason for this is, if this young girl continues to take the virus into her body, and from the body, as the delivery occurs, there is a large amount of intermixing of the fetal and maternal blood. So it has been shown that if the mother is carrying active viral replication, she will transmit it to the baby. And that unfortunate young baby who's been born with the infected mother, if we as hepatologists, or you have obstetrician or a pediatrician, are negligent, have not looked at it, this baby is going to be stuck up with hepatitis B lifelong. That is something which is unfortunate. It is none of the fault of the baby. So we must make all efforts to screen for hepatitis B. And if the virus is multiplying, we should give this drug called TAF, so that by the time she delivers and there is an intermixing of the maternal and the fetal blood, so no virus gets transmitted to the baby. And the baby which is born at birth should be given immunoglobulins and hepatitis B vaccine by the pediatrician, who should be ready with everything. So many times we have seen that delivery typically will occur at odd hours of the day, more than any of us will know. They'll occur earlier morning or late evening. Then you cannot have any excuse. Pediatrician should not have any excuse, okay, I did not get this immunoglobulin, vaccine was not available. It is our duty as a physician and obstetrician to be keeping everything abreast and available quickly at the time of delivery, so that the baby is given these antivirals and immunoglobulins to save the life of the baby for future problems.
Very rightly said, sir. In case we know that patient is hepatitis B positive, so it's our duty to inform, first of all, our gastroenterologist colleague, and other thing, to keep the immunoglobulin and the vaccines ready, and all the precautions. See the viral levels, whether this is active viral level, is more viral count, as you said, and start and continue with the antiviral disease of the hepatitis B, which is relevant to give during the pregnancy. That's good.
We have written these guidelines on management of liver disease in pregnancy We had with Fogsi, when I was the president of Indian National Association for Study of the Liver Disease,
Sir.
collaboration with
Great.
Fogsi, we have come with guidelines of managing liver disease in pregnancy. It's a beautiful document available online. Anybody can refer to that.
Okay, sir, it's great. We will take definitely reference of this and be benefited by this information. And the other thing is, as we obstetricians are, especially I have seen too many obstetricians who usually want to avoid. If we used to know that this is a patient who is having HbSAg positive, and we don't take this type of the patient, and patient go on running from one hospital to other hospital. So what are your guidelines about that?
I think it is a very relevant question, ma'am, you have raised. So many times we have seen patients in the periphery when obstetrician wants to play safe. The moment they have seen a patient with hepatitis B, so the patient is just shunned around. I mean, उनको लगता है कि अछूत patient है. I mean, that's very bad. You see, nobody is ready to touch. Sister will run away, obstetrician will run away, and कि ये नहीं होगा, वहाँ चले जाओ. At the now, a person, a lady who is full term, is poor, how the hell would she travel to a tertiary care center? She might deliver on the way. And you have been looking after her antenatal care for almost 9 months, and suddenly you tell her that you will not deliver. Delivery of hepatitis B is as simple as delivery of any other women without hepatitis B if the pregnancy is full term, except that you have to maybe use double gloves and take extra precaution that during cesarean or during delivery you do not get exposed, especially in terms of cuts because of the infected blood. Short of that, it's as simple and as safe whether you need to do cesarean or you want to do a vaginal delivery or you want to put in forceps. That onus lies on you. As a hepatologist, we cannot be the watch guard, we cannot be the custodian to tell you what to do. You are the best judge sitting over there. Any delivery is safe. So please never ever think that hepatitis B is difficult to manage. The only thing is you have to make the patient aviremic prior to delivery. Short of that, obstetrical principles remains absolutely same. So there is no point of referring this poor young lady to a tertiary center hospital where they'll say, "Oh, she didn't have antenatal care with us, so we'll not admit her." So the patient will keep running from one tour to another. That is, if we can leave that simple message from this webinar, I think it will be worth it.
It's a great message, really, sir. You have given to all the 46,000 Foxians, obstetricians who are watching this podcast that we should take these type of the patient and help them and deliver them. Of course, we should take double precautions for our face mask, double gloves, etc. And try to make, if the patient comes a bit earlier to you, try to make her aviremic. It's our duty to start a proper medicine, take the help of your gastroenterologist colleagues.
Yeah.
And in case, sir, the patient come in emergency and by chance you are operating the patient, we are operating the patient, suppose delivering normally about the episiotomy or by the cesarean section, you got a prick, as usual question by many obstetrician colleagues. What is the further procedure you will recommend?
Yeah, can I just,
There is a lot much of panic in these many cases.
yeah, can I just add two more points to the previous query? One is that once we tell this patient, "Oh, कि ले जाओ, हम delivery नहीं करेंगे," so that way we are socially ostracizing this lady. Look at her plight. She's in
Very
a pregnant state. She's about to deliver, and the family looks at her with suspicion. The
Right.
relative looks with her suspicion कि क्या है, infected है, क्या है. That is something which is criminal, I presume.
Criminal.
So look at the
That is a
societal
message.
pressure.
Yes.
Societal pressure she has. She
Very
should not be ostracized. Why?
Right.
What is wrong with her?
Right.
That's number one. Secondly, we are all worried about our getting pricked from a hepatitis B patient. But I like to know, you have 46,000 Foxians. Is it possible to have a vote from them? How many of them know that they have been protected with vaccine against hepatitis B? If there is a some vote count or some information available, just see how many of them have already got vaccination and have ensured
Almost
that
all.
their
Almost
vaccination,
all. Yeah.
Yes, just cross-check that the vaccination has produced antibodies. So if you are
Right.
protected against hepatitis B and your antibodies are positive, then the prick does not matter.
Right.
See, if you already have a vaccination and your antibodies in the blood are more than 10 anti-hepatitis B surface antibody, then whether you get pricked or not, it does not matter because you cannot have hepatitis B.
Sorry to interrupt. That means when an obstetrician is being pricked by the needle while operating such an infected patient, she should get her surface antibody test done, and it should be more than 10.
Yes,
Then
you
there is
can
no
get it
risk.
done otherwise also. See, even now, without prick, you know your antibody test, say it is 200. Once it is 200, you never need to get it checked again. That is the beauty of hepatitis B.
Oh, right. Great.
Antibodies levels may come down, but your protection never goes down. It is a one-time vaccine, gives you 100% protection if your level goes beyond 10. So if one time see, now you're practicing gynecology almost daily, you're practicing obstetrician. So at least once in lifetime, see your antibodies more than 10. After that, you don't need to repeat it. That
Right.
gives you assurance. Problem occurs is most of us have not checked up our antibody. That is the reason we get into panic mode the moment we get pricked. Then we know what is the status. So what we have to do is see your own status, whether you are antibody protected or not. See the status of the patient from whom you got the prick. What is the level of viremia? Get an immunoglobulin if you are not sure of your vaccination status, and take a vaccine immediately. These are the 4 things you need to do.
So vaccine, if once a person, an obstetrician has taken once in life, so she has to be repeated with the vaccine or not?
There is a primary course of vaccination. 3 vaccines are to be taken: day one,
Okay.
1 month, and 6 months.
Right.
And
This is
after 1 month after the last dose, that means 7 months after the first dose, if you get your antibody test done, and if it is more than 10, so you have a 100% protection.
right. And what about in case has not got any, suppose it has been pricked and she is under very much chaos, ki what will happen? So she should take immunoglobulins immediately.
Yes.
And
If the obstetrician or any medical personnel, your nursing staff, your technician gets pricked, and if they are not aware of their antibody status, quickly get an antibody done. If it is getting late, do get an immunoglobulin, hyperimmune serum globulin for hepatitis B, H big, and get a vaccine. And wait for the results of your antibody and the status of the patient.
okay, sir. Rightly said. And this is about hepatitis B. I just want to know about hepatitis C also.
Yes.
We do get investigation for HB, hepatitis C.
Yeah. So as you had raised a very
patient is
pertinent
positive.
query, of if patient is incidentally found to be hepatitis C prior to conception, so you have 3 months of medication called direct acting antiviral DEA, which gives you almost more than 95% cure rate. So before conceiving, get this treatment and then you are as good as normal. But if you have already conceived, as of now, we believe that antiviral drugs for hepatitis C, C for Calcutta, should not be given in the pregnant state because there is no urgency. So let the mother deliver the baby, and then once the delivery is done, then you wait for 6 to 8 weeks and then start the antiviral therapy. But there is some increasing data which is being recently published, is that maybe these drugs may become safe once we have more evidence of their safety, even in hepatitis C patients requiring DAAs. For the time being, hepatitis C should not be treated in pregnancy.
Okay, very nice. In case I'm asking about, sir, if the patient is hepatitis C positive, that is being investigated a bit late. Patient come from some rural area and surgeon while operating get infected. And she is knowing about that the patient is hepatitis C positive. What is her duty? How can
Yes, you take the same universal precaution. Now, as against hepatitis B, where you have immunoglobulin to protect the baby, and you have hepatitis B vaccination to protect the baby, unfortunately, there is nothing available to protect the young baby from the infected mother. You do not have immunoglobulins, you do not have vaccine for hepatitis C. Since hepatitis C is totally curable, it's almost 100% curable with the currently available medication. So don't be bothered about transmission to the baby. The chance of transmission of the baby or hepatitis C from mother to the baby is to the tune of 7%. And by the time baby grows up, even if there is a delay of few years, it does not matter. You have absolutely safe drugs which can be given at the second year of life and which can be totally curative. So C is far simpler to treat. Problem is B, because B is the virus which gets into the nucleus of the host and does not leave it. It just clutches onto the nucleus. So B is far more difficult.
Rightly said. In case hepatitis C patient, we are operating on that patient and being pricked, then we don't have to do anything but wait whether our immunity will compromise it, or otherwise our immunity, we will get infected, and after 2 months we will be knowing about it. Na, sir? And
After the last dose, which is given at the end of the 6 months. So day 1 month and 6 months. On 6 months, you take the third dose, and 1 month after the last dose, you get your anti-hepatitis B surface antibody done, anti-HBs antibody. If level is more than 10, then you have a lifelong protection. You never need to repeat your antibody test. But that is what I wanted to know about this 46,000.
hepatitis C, sir. I'm asking about hepatitis C, please.
See, there is, once you have been treated and cured with antiviral drugs, it is a complete cure. You don't need to look for antibodies. You may need to repeat an HCV RNA 6 months after completing the therapy, but then there is no vaccine for it. And once it is cured with, after 6 months of stopping the therapy, then you're totally cured. You don't need to keep chasing it.
Okay. Thank you. Thank you, sir. Thank you very much for giving a great message, enlightening all of us. And any other message for we obstetrician in this podcast from your behalf?
Yes, one thing which is very important is that, as a rule, all females who come to you for any consultation, you need to be doing their hepatitis B antigen antibody and also do a hepatitis A virus antibodies. Nowadays, we see a lot of young people eating out and then having late night dinners and asking the food from these food chains which are available easily like Zomato, etc. So from there, once you have an infected food, you can get hepatitis A, which can be troublesome in pregnancy. Earlier, hepatitis E used to be troublesome in pregnancy. Now, hepatitis A is becoming problem. So vaccinate all young women with hepatitis A and B. Once they are on oral contraceptives, do take care of their liver function status, because oral contraceptives can give you cholestatic liver disease. They can produce tumors in the liver, which can be in the form of focal nodular hyperplasia or more likely hepatocellular adenomas, and they can aggravate the problem of underlying liver disease. So once the patient is on oral contraceptives, so their liver functions need to be monitored. They should be taken for a fixed amount of time under the supervision of an obstetrician, and you have to regularly monitor their liver function test, because hepatic adenoma, which has a good relationship with the oral contraceptive use, some of the varieties can even turn malignant and give you the problem, and they can get, these lesions can get bigger in size. They can get stimulated in term because of the hormonal stimulation during pregnancy and can give you the trouble.
Oh, thank you so much for giving us great message, because the liver function, usually we all the obstetricians are afraid of, if any disease which complicate the pregnancy, like the liver function test is worsening, or any liver disease with the pregnancy, with the kidney disease of the pregnancy, all these diseases usually make us a bit in chaos. So thank you for enlightening all of us, and thank you. Namaskar.
Thank you so much.
Yes, thank you so much.